To welcome you to the webinar resident series session is Expand Your Digital Knowledge with the iTero Elements. And it is being presented by Kelly Bevington, RDA, EFDA. And with that, it is my pleasure to introduce Adam Dreyfus, Corporate Account Manager, University, Government, and Institutions.
I am so excited that we're able to bring this topic to you today. It's been brought up to me about you guys wanting to learn more about digital, and I am so proud and happy to bring the resource that we have internally to everybody. And without further ado, I'd like to turn over our presentation to NDX's Director of Intraoral Technology, Kelly Bevington.
Thanks so much, Adam. Appreciate it. Good morning, everybody. So this is my passion. This is what I get excited about. I've been working with intraoral scanners for over a decade, and we have a team of trainers here at NDX. I'll get into that here in a moment. But we're going to talk about the very foundation, the very basics of intraoral scanning and how best to achieve that. And then we've got follow-up courses as well that will get into specific items. So with that, let's move forward here. So a little bit about NDX. You can see that digital is our focus. And one of the key components of scanning intraorally is how simple and seamless and accurate it is for implant work. So we're super excited about that. This is the team that I mentioned. So we are all clinical dental people from our original career. I was a RDA EFTA for many years before joining the lab. We have a registered dental hygienist, Brittany Carey. We also have a CDA RDA, Brenda Kirkin, who actually worked at University of Detroit Mercy as faculty. So she's very accustomed to the world of academia and training people who are not only new to digital, but new to dentistry as well. And then we have a dentist from the Philippines, and that's Benister Poe. And Ben was a key individual. I'm not going to get into a lot of our bios here, but a key individual at 3Shape, training for Trios as well as Nobel Biocare with implants. So what people will often ask, why go digital, right? And this is an older slide, but it's still very accurate, right? Digital is statistically, we have data now that statistically proves that a digital impression, a good digital impression, is more accurate than a good polyvinyl siloxane impression. Typically for the patients, it's a much easier process. It can be an exciting process for them. It can be a tool for the dentist to use in properly educating that patient on what their dental health is and the needs that they might have. Once you are proficient, it definitely saves you time in taking a scan versus a PVS impression. And then, of course, the overhead of the impression material long-term. People will often ask me, and I know that since this is a residency program, most of you are younger, right? What I have found is that it takes different people with different skill sets a different amount of time to really grasp the technology. So for an older dog like myself, when I was learning, it probably took me a good 15 to 20 scans before I felt comfortable, confident, and able to teach the next person how to do it. And then there are younger folks, probably such as yourselves, that have grown up with hand-eye screen technology. It's different than just hand-eye coordination. You really need to be able to look at the screen and glance in the oral cavity, or vice versa, glance at the screen and look in the oral cavity while moving the scanner. So for some people, that's a little bit of a struggle. It feels like they're driving backing up in a rear view mirror. So just know that that's normal, right? So just because one colleague has it down pat after 2 scans and it takes you 10, it's not wrong. It's not bad. It's very, very normal in the industry. So this list of what can we use a scanner for, what are the indications, has morphed, right? It used to be for new patient scans, for aligners, for bruxism appliances, and maybe crowns. And then it continues to grow year over year over year. And what's super exciting to me is the third line down, removable full and partial dentures is like, wow, 10 years ago, I never thought we would be able to scan for dentures and partials, but we are. I like to call it digitally assisted. It might not be 100% of a digital workflow from the get-go. It really depends on your patient's anatomy and the quality of the very first scan you can capture, and if they have an existing denture or partial to help with the vertical dimensions and bite registrations. But so anything that you take a PVS impression for today, you could also take an intraoral scan or digital impression of now. The only one I personally am a little iffy on are inlays and onlays. Like there needs to be a definitive finish line cut into that preparation that is replicated in the digital impression and therefore the model that is formulated from it, the digital model. And if that finish line isn't there, then it can make inlays and onlays a little tricky. So why go digital? Some of the reasons that I mentioned earlier, right? It's easier for your patient. It can save you time. It can save you money. It's also a really cool wow factor for your patients. And I like to share a little story about what I experienced with my husband. So my husband and I went to the same dentist for many years. Post-pandemic, he wanted to see a dentist that was closer to where we lived and where he worked. So he changed and went to a different dentist. Super practice, really nice guy. His old dentist had been telling him that he needed a crown on number 14 for probably 2 or 3 years. And he's one of those people that, if it's not broke, why fix it kind of thing. It didn't cause him any discomfort. He didn't notice anything unusual about it. And it had a large amalgam filling that had fractured. And that really didn't mean anything to him, apparently. So the new dentist, the very first thing they do at the new patient appointment is they took a digital scan, just a wellness scan, an introductory part of your new patient exam, part of your permanent records at the practice. And at the end of that appointment, the dentist came in and reviewed the scan with them. He said, and can you see this tooth up here? It has, it's pretty black. It has a large amalgam filling on it. And there is a crack right through the middle. It really needs to be repaired because that crack is going to break apart and it could potentially fracture your tooth structure underneath. And he was like, oh, my other dentist told me I needed that, but I never saw it like that. I didn't realize what was going on. And he had the crown done like he scheduled that day. I was like, So I like to share that with people because the way in which we educate our patients makes a difference, right? Like they don't always see what we're trained to see on an x-ray or even a model of their teeth, but somehow when it's color and it's larger than life on a monitor screen in front of them and you can really highlight what's going on, it makes a big difference for them. What else? Are you like technology driven? Most people today are pretty techie. And they enjoy being able to showcase that technology expertise in their work environment as well as their personal environment. And what are your file needs? So I know we're a lab, right? But there are file needs with intraoral scanners if there's any aspect that you don't want to send that file directly to a lab. Maybe you want to send it somewhere else for some sort of an evaluation. Maybe you're going to be combining it with CT scans and preparing surgical guides. Maybe you're looking at some sort of in-office milling, things along that line. And then I always like to throw in demonstrations. It's so important that you experience some different scanners, like in your hand. Go to a trade show, call your representative. When your sales representatives come into the practice, once you're graduated and out there in the real world, right? Take advantage of learning about the different systems from the representatives and experiencing those demonstrations. I think you'll find it to make a world of difference. And so I'm just going to briefly identify like the top scanners, not top in that they're the best scanners out there, but top in who we receive scans from, right? So very, very high level. We receive over 3,500 scans a day, right? I just wanted you to see some pictures. So this is a photograph of, or an image of what the iTero scanner Element 5 looks like. Then we have the Trios intraoral scanners. That's a 3Shape is the manufacturer. Prime Scan is a Dentsply Sirona product. This is their latest and greatest version. And then we have Medit, who has been sort of growing at a rapid speed, if you will. And so those are the systems that we immediately are able to provide different type of training and in office or in clinic hands-on assistance with. The others are, equally as good. We just receive more scans of the ones I just mentioned. And then this is a document that we have created, and I can provide that to you, Adam, as well as perhaps a follow-up to the attendees. It's really like best practices on obtaining the best intraoral scan. And part of what it is going to discuss or highlight to you is the importance of isolation. The oral cavity has to be dry when you're taking an intraoral scan, as well as gingival tissue management and retraction for crown cases or implant cases. Just a reminder of a prep guide, right? So depending upon whether you are doing no metal substructure or PFM, we really want to make sure that we are prepping with a shoulder or a chamfer without sharp line angles in order to get the best scan for it to acquire the best way, as well as fabrication. And these are some examples of items that I've used in my hands that I find work really well to retract lips and cheeks. And this is primarily if you're scanning all by yourself, right? So I presume the attendees here are dental residents, right? So if you're working without an assistant, some of these items can be very helpful. My go-to is the NeoDry by Microbi. And it's a triangle that goes against the parotid gland on the inside of the cheek. It works wonders. It's amazing that we don't really think about it, but when we're using the scanner and we retract the cheek, we're pulling the cheek, we sort of milk that parotid gland, and then all of a sudden there's a bunch of saliva on the mandibular arch, and you're wondering, where is this all coming from? So that sort of puts that at bay. The ScanMate here in the center, that is an autoclavable instrument that is very soft and flexible, and it can be used very nicely to retract the lips, specifically when scanning intraorally, specifically on an edentulous patient. Very, very helpful. And then the lip and cheek retractors, Optrogate is a single-use disposable. And for those that are very green conscious, the Comfort View is autoclavable and reusable. Both work equally well. I like them both. So one of the things that we find as a lab is that oftentimes the preparation that is provided to us is not as ideal as it could be, that there wasn't an adequate amount of occlusal reduction on that prep before the scan was taken. So all of the systems out there now have tools and features that allow you to cut away or erase the occlusal surface of your scan, take the burr, recut the prep, and then rescan your prep tooth. It's a nice feature. Sometimes the merging of that data, the stitching of that data isn't as great as I would like to see it. So as with most things, from a foundation standpoint, check, right? Just double check that you have enough occlusal reduction before you ever take a digital scan or a physical impression. And so I will ask people about that. And, a lot of times people will say, oh, I eyeball it, been doing this a long time, or they haven't, and they still say they eyeball it. Well, I mean, that's good, but think about, the distal buccal cusp of number 2. That can be challenging to eyeball it. Can you really see that well? So there's a couple different ways you can do that. So Prep Check, this is the image of Prep Check here, the little green device. It's like a boomerang. You hold the one side, you have the patient bite into it, tap, tap, tap. And if it does not have, let's say 1.5 or 2 millimeters, they come in different widths, different depths, it will leave a mark on your prepared tooth. So that it's like a no-brainer. Okay, that's where I go back in and re-prep. There is an expense to it, right? I think they're 60 cents a piece, something like that. So you could use like wax. Wax is super inexpensive. Measure it with a pair of calipers, or if you make the temporary provisional before scanning, you could measure the temp and make sure that there is enough. Also, most ball burnishers are just the right depth. They're at like 2 millimeters. That is ideal for you to be able to slide through when the patient is closed. So just a couple observations of what are the most common reasons for a scan to be rejected. And so enough occlusal reduction is a big one. Now, can the lab work around that? Yes, of course. Just like you would with a physical impression, you could tell the lab to provide you a reduction coping, and you will use that coping to reduce the prep additionally at the time of inserting the crown. Or you could ask the lab to reduce the opposing dentition to make adequate spacing. For some people, those are options that they would prefer not to do. So optimally is to make sure there's enough reduction right from the get-go. This is an image that I really like. Dr. Duplantis provided this to us, and it is, it's ideal, right? So the gingival tissue has been properly retracted away from the prep, and it's exposing the margin, the finish line. This was done a combination of hemostatic agent as well as retraction cord. You can use retraction paste, you could use laser. There's multiple ways to achieve success. I encourage you to use something, because if the tissue is butted up next to the prep, we lose the finish line. On a digital impression, there needs to be specific definition from the finish line or the margin against the gingival tissue. And one thing that I hear frequently is, Oh, well, I'm very conservative and my preps are supra gingival. Well, that's great. Yeah, I would want that for my own dentist, right? But it's not always reality either, because sometimes decay goes sub G and we need to be able to deal with that as well. So I'm a big proponent of a double cord retraction technique. So I will use a double or triple zero first, followed usually by another double zero. This is a packing instrument that I find to be helpful, and I'm a big believer of Viscostat. I do not have stock in Ultradent, but I wish I did actually. I think Viscostat is fabulous, and I've used like lots of the different generic brands, and there's something different. And it has a really nice little sponge applicator on it that you can sort of burnish it into the tissue if you have a bleeder. So that's very helpful as well. And as I mentioned, there's lots of different ways to achieve proper gingival tissue retraction. Another thing that you could do is to combine a couple different things, right? Retraction paste is great as long as it's used appropriately. So oftentimes I see people use retraction paste and they just sort of express it on the sulcus, or not the sulcus. They just express it on the tissue, and it's working as a hemostatic agent, but you need to express it into the sulcus for it to actually expand and push the tissue away. So a fine tip on the applicator is really important. However, the finer the tip, the more difficult it is to express it, to squeeze it out of the applicator. So it might take a little time trying a couple different brands before you find one that works really well in your hands. In combination with retraction paste, I very much like the Compra Caps. That's the image to the far right-hand side. It's sort of like a cotton roll that's been cut in half, but it has been trimmed away for the mesial and distal interproximal areas, and you have the patient bite into it. So you could put the cord or retraction paste down first and then have them bite into it. And that additional pressure helps to retract the tissue away from the tooth itself. And it does provide hemostasis also. The other thing with retraction paste is to remember that as soon as you rinse and dry, you want to scan like immediately before there's an opportunity for the tissue to collapse. That's a big deal, big deal. So I'll go into private practice and the assistant rinses everything off. And then she goes and gets the dentist to come and scan. It's like, no, now the tissue's already collapsed. So it needs to be, it scanned immediately after rinsing. Super important. And so people will ask me about other materials, blue mousse inside of a temporary, or Teflon tape. I mean, I've come across some really strange things. Rotary curettage, not a fan. For PVS, it might work fine. But what happens when the tissue is cut is that then, even if it's not actively bleeding, it's raw. It shows up almost reflective in the scans themselves. So be very careful about rotary curettage and about laser. So laser, and I'm not sure if it's the device itself, the hands of the person using it, or the patient's tissue. But sometimes laser comes off, it's really nice and smooth and clean, and it looks great. And then other times it looks more like electrosurge, and it sort of has hills and valleys of lumps of tissue that the light of the scanner has to be able to see over top of. And that can be difficult to acquire that type of a scan. So be careful with electrosurge and the final results from laser. So we talked a little bit about different systems that we receive scans from. So as I mentioned before, iTero by Align Technologies is who we receive the most amount of scans from. Next in line would be 3Shape's Trios device. then Medit, and Prime Scan, and then the others, and they all sort of mish and mash every month. It's a little bit different, but there's new scanners coming out every day. I'm sure there's a scanner that I don't have on here now that has come out in the last month. Most of them are fairly similar to Medit and Trios when they are private labeled by other companies, is what we're finding. And then, of course, you can scan for implants. You can use in combination with CBCT scans. Implants are really interesting because it's a part that you're scanning versus the actual dentition. So it's critically important that you're very aware of what type of implant your patient has and ordering the proper scan body, because you're going to be scanning a scan body instead of the natural dentition. So this is an image of a 3-shape scan body. And what's important to know and identify on the RX, and every scanner has something a little bit different. iTeros is probably the most comprehensive RX when it comes to implants, as there's multiple drop-down menus for you to identify the implant that you have scanned with the scan body. So you always want to be able to tell the lab who the implant manufacturer is, what type of a scan body you used, the platform size of that scan body, what type of a custom abutment do you want, and what type of a crown material do you want? And then lastly, you want to identify whether you want that crown to be cement or screw retained. And that has evolved over the years. I've been in this industry most of my adult life, and I will say, 25 years ago, everything was screw retained. And then we went to cement retained, and now we're back sort of to screw retained again. So as with most things in life, it's sort of an evolution, and what was once popular becomes popular again. So just know that those are all variables for you. It's really important to have the appropriate scan body and take a radiograph of it to ensure that it's properly seated. So this is an example of a PA that was taken of the scan body. You can pre-order that scan body either from your implant manufacturer or from the laboratory. I highly recommend full arch scans for any implant. If you think about it, an additional 30 seconds to maybe a minute of taking full arch scan and bites versus a quadrant, it's worth the investment, right? An extra minute in that foundational time of taking the initial scan is worth that investment. The reason it's important to take the radiograph is it's the foundation, right? So if it's not fully seated now, the case is a bust. It's not going to work. And there are some scan bodies out there. Most are finger tight. Some are snap in, so you push with pressure. And the ones that you push with pressure tend to have like a double lip. So you push once and you feel it click, and then you can push it again and it clicks again. And we found that out the hard way. So we had several cases that from a particular manufacturer that was pressure sensitive, and they weren't working. And so by going chair side and assisting and working with the clinician, we were able to, and taking radiographs, we were able to figure out that double lip snap existed. So it's really important. If the scanner that you're using has an opportunity for you to take a pre-treatment scan or two scans of the operative arch, one before the scan body and one without the scan body, I highly recommend that. So you would remove the healing cap, take a scan of the tissue before it starts to collapse. And that's what we're going to use to design a beautiful emergence profile for your crown. And that's the key, is to take that scan before the tissue has an opportunity to collapse. And every system out there is a little bit different as to in what order you take those. And this is just an example of what a cement retained crown would look like versus a screw retained crown. There's pros and cons to each, some philosophical differences that you will make decisions on for yourselves. And then, of course, we can take scans for dentures as well now. So just highlighting some exciting things that we're able to do with intraoral scanning. And so this is what I refer to as being digitally assisted, if you will. So there are copy denture workflows, immediate denture workflows, there's hybrids, and there's reference denture workflows. And I would say I've had the greatest experience with the reference denture. And the reference denture, you're actually going to use the patient's existing prostheses as a tray, if you will, and will take an impression inside of their existing denture, scan that, have it in the patient's mouth, build up the bite to the vertical to where you want it to be, and take the bite registration at that point. Depending upon where you are in that process and how accurate of a replication of the muscles that you were able to acquire will be dependent upon whether you get perhaps a functional try-in back, right? So teeth set, and it's a functional try-in, like the patient could actually, it's down here at the bottom is the imagery. The patient could actually leave with that try-in and test it out. You can make modifications to the try-in, to the bite. You could, rotate a lateral or shift to your midline. You could do lots of things with the functional try-in. Otherwise, you are going to perhaps, if your impression wasn't that great, or the patient did not have an existing prosthesis and you scanned intraorally, you might just be getting back, worst case scenario, a custom tray that you then could take the impression and then scan the impression. So people are like, well, why would I scan an impression versus just sending you the impression? Well, it's all about that workflow, right? And if you want it to be digitally designed and a complete digital workflow, once that intraoral part of the scan is achieved. What people fail to realize is taking an intraoral scan of an active patient can be really challenging, like really challenging. You're going to want to have a dental assistant with you to help retract the lips and cheeks. However, if you think about it, when you retract the lips and cheeks, then you're changing the muscles and the vestibule, because that's not the way they're going to be positioned when you insert a denture. So it's a fine line that we sort of walk with taking an intraoral scan. Also, when taking an intraoral scan, you want to make sure that you're capturing like the post-stem area. You want to make sure that you're capturing the retromolar pads and the hamular notch and all of the anatomical landmarks that you would obtain in a physical impression. You have to do intraorally, and that can be difficult to see, and it can be for some patients it can be a little uncomfortable. If you have a gagger, it's going to be uncomfortable for them one way or the other, whether it's with a physical impression or a digital impression. But it's it's a great technology. It's allowing us to do a lot more than what we've been able to do in the past, and the patients are super excited about it. When you're scanning intraorally, the tissue needs to be dry, and it needs to be, you need to go slowly, like very, very slowly, to stitch the data together. If there is an option on your scanner to turn AI, artificial intelligence, off, you need to turn it off. So AI in the intraoral scanning world was a godsend probably 5, 6, 7 years ago when it was first developed, because what it did was it automatically removed fingers, instruments, lips, cheeks, tongues from our scan. So it was awesome, right? The scanner had got smart enough to only scan dentition. Now we're asking it to scan tissue, and that's why you have to turn AI off, because as long as AI is on, the tissue is not going to stitch together appropriately. Now, I have been told that this next thing I say, really, it isn't the scanner making a difference, it's my eyes and my mind going slow enough. So what I do is I take a Dr. Thompson stick. It has like indelible sort of watered ink on one end. And I'll just use the maxillary arch as an example. I will make like an arrow down the midline, and a couple X's at the post-dam area. Hopefully the patient has a well-developed rugae that also helps to capture intraoral scans. And then I follow those lines and I follow the X's. So yes, my mind is going slower and I am methodically following the lines that I've created. Otherwise, when you look at the screen, it's all pink, right? It's all gingival tissue, and it's difficult for you to discern exactly where you are in that scanning process. So this is potentially the new try-in, right? It's exciting. It's exciting for us as a laboratory. And that's an example of those impressions inside of the denture that were scanned. Another try-in design. And that's the functional part that I mentioned. And printing and milling is done, and that continues to evolve and change as this technology just becomes more and more requested. And what's the most cost-effective way to do it? What's the most time-efficient way to do it? And so those kind of things continue to evolve when it comes to removables. And this was a little bit about taking a pre-treatment scan to retrofit a partial to a pre-existing, retrofit a partial to a new crown, which is something that comes up periodically, but not a tremendous amount of time. And then this really concludes this big overview. What can you do with intraoral scanning? I hope we hit some spots for you that were potential aha moments, or that you were able to take good notes about or have questions about. So if you have further questions, please feel free to reach out to me. That 800 number comes directly to my phone as well. And so thank you very much.